Good morning, friends. Welcome to yet another episode of my ECG quiz. I hope you are enjoying these sessions and getting all your answers correct in all the sessions. Today I shall discuss two 12-lead ECGs and one arrhythmia. I hope you are already ready with your pen and paper. I presume that all of you have the hexaxial reference system in front of you, that diagram, to help you calculate the QRS axis, because in some of the 12-lead ECGs, I will be asking for a QRS axis evaluation. Okay, so we'll go on to the first slide. Now this first slide shows the ECG of a 69-year-old diabetic gentleman. He was 69 years old and he was diabetic. He was admitted to the hospital with a history of sudden onset of vomiting and giddiness one day before admission. Now my two questions here are, what is your diagnosis from the ECG? And second, elaborate the changes which occur in this combination of ECG findings. So there is an ECG finding or one or two ECG findings. So I want you to elaborate what other changes which may not be shown here or may be shown here are expected in this type of patient. So friends, we will go on to the answers to these questions. Now, what do you see in the ECG? It shows a widening of the QRS complex here, isn't it? Lead 1 shows widening. On measurement that comes to 4 millimeters, which will turn out to be 160 milliseconds, isn't it? So there is a QRS widening. Now, lead 1 and AVL both show positive QRS complexes, whereas lead 2, 3 and AVF show negative QRS complexes. So this RR prime pattern here in V1 and lead 1, and AVL indicate a left bundle branch block in this patient. So that is a confirmed point. But then what else does he have? Now you concentrate on the precordial leads. V1, V2 and V3. All these three showed an elevated maximum here in V2, elevated and code ST segment, which is about 5 millimeters, isn't it? Suggesting the possibility of anterior wall, acute anterior wall myocardial infarction. Now, in the presence of left bundle branch block, it may be difficult to diagnose an anterior wall myocardial infarction. And there are certain signs or certain ECG findings associated with this. One of this is an ST elevation of more than 5 millimeters, which is discordant, that is opposite to the QRS complex. And here you can see there is a 5 millimeter here, and possibly it is 5 millimeter here also. This is called the Scarbosa sign. We have discussed this in the discussion on the left bundle branch block with myocardial infarction, right? Now, second point, if you look at lead V1, this shows a small R wave. Normally in left bundle branch block, we said that the R in V1 disappears, and if there is a Q in V6, that also disappears. Whereas the appearance of an R in V1 is a point in favor of a myocardial infarction. Now we come to V4. Now V4 shows a notch in the S wave. Actually, a notch in the ascending limb of the S wave is called a Cabrera sign. This is not in the ascending limb, but still can be taken as a positive sign. Now, lead V5, V6 show positive T waves, right? V5, V6 show positive T waves. Normally, in a left bundle branch block, we expect T wave to be in the opposite direction. The ST is depressed and the T is inverted. This is called the discordant change, which is normal for an LBB. Whereas if it is positive, that is the T wave is in the same direction as the QRS, you call it concordant. So the presence of concordant T waves in V5 and V6 is another sign which tells you that there is an anterior wall myocardial infarction here with a left bundle branch block. Now, what I asked you whether there is something else which can occur. The other changes which are not there here, right, is an ascending limb of AVL or V6 or lead 1. These may show a notch, the ascending limb. That is called the Chapman's sign. And there is one more sign which is known as the dome and dart appearance. That is, you get a domed appearance followed by a sharp R wave. That is called the dome and dart appearance, which may appear in V5 and V6. So these are the changes which will appear in patients with left bundle branch block and myocardial infarction. So this diagnosis will be LBB, acute anterior wall MI, Scarbosa sign, which is the ST elevation here of 5 millimeters, code ST elevation, and Cabrera sign, which of course is not a classical one here. There should be a notch in the ascending limb of the S wave in V4. These are the changes. Now we will go on to an arrhythmia. This is my second ECG. Now this is the lead 2 rhythm strip of a 20-year-old. He was a 20-year-old boy who came to the cardiac ICU with history of retrosternal pain of 3 days duration. Now the pain was increased when he took a deep breath and also when he swallowed foods or liquids or anything. So the question is, what is the ECG diagnosis of the arrhythmia and what could be the cause of his symptoms? So you can start answering this also. So friends, we'll go on to the discussion of this ECG. Now what do you see here? You can see that the QRS complexes are narrow. It's a regular narrow QRS complex arrhythmia, isn't it? And this RR interval here is 4 large divisions. That is 300 divided by 4, then will give you a rate of 75 beats per minute. So the QRS is coming at a rate of 75 beats per minute. Now look at the P waves. These are the P waves. I have not marked them with arrows. There is a P wave here. There is a P wave and the T wave here. Another here. Another P wave here. Another is on the descending limb of the QRS. Another is here. Next one is here. Thus you can see the P waves regularly coming. Now the P waves are coming at a faster rate of 125 per minute. Actually the PP interval works out to be 12 millimeters, and so they are coming at a rate of 125 per minute. So the patient is having a sinus tachycardia, isn't it? But at the same time you find that the QRS and the P waves bear no relation to each other because the P seems to walk through the QRS complex. So that is AV dissociation. There is atrioventricular dissociation in this patient, right? So atrioventricular dissociation, sinus tachycardia. Now let us concentrate on the QRS. Now the QRS we said is not a conducted beat because the P waves are not there in front of the QRS. So sinus beats are not getting conducted. So this is arising from the junction, isn't it? So being narrow, it is arising from the junction. But the rate is 75 per minute. So a rate arising from the junction, focus in the junction, beating at 75 per minute, you would tend to call it a accelerated junctional rhythm, isn't it? Now the other finding in the ECG here, if you look very carefully, you can see there is an ST elevation here, right? Yeah, an ST elevation with the concavity directed upwards. What are the conditions which can produce that? Of course, the first thing which I am sure you would say is a hyperacute myocardial infarction, because we are giving you only one lead here in an arrhythmia. We can't say which is the infarction. It could be lateral wall, it could be inferior wall, whatever. So hyperacute myocardial infarction is one diagnosis. Another we said is an early repolarization syndrome, because we told you that the patient is 20 years old. So it could be early repolarization syndrome, which is seen sometimes in normal young adults. But the changes are usually more in the precordial leads, V2, V3, etc. Whereas here this is lead 2. The third condition is pericarditis, acute pericarditis. Acute pericarditis, what is the change? ECG change is a ST elevation with a concavity directed upwards. Now this patient gave the symptoms of retrosternal pain on deep breathing and swallowing. These are two classical symptoms of pericarditis. That is, the patient gets deep pain, right? When he takes a deep breath, he gets a retrosternal pain. And similarly, during swallowing, sometimes even during sneezing and coughing. And similarly, if he bends backwards like this, the pain increases. Bending forward relieves the pain to some extent. Now these are some signs of pericarditis. Read about pericarditis in some book, textbook of medicine. So this was a classical case of pericarditis, acute pericarditis. The patient had a classical triphasic pericardial rub heard in the precordium, and this turned out to be due to tuberculous pericarditis on later investigation. Okay, and he was treated, he became better. So the changes of pericarditis are noticed in almost all the leads, except maybe leads like AVR, sometimes in V1, right? Except these two, it is seen in all the leads. So it doesn't conform to a lateral wall, inferior wall, anterior wall like that as in myocardial infarction. So we call it as global ECG change or a global change which affects all over all the territories, right? So that is the classical side, the finding in acute pericarditis. Read about it somewhere. Okay. Now we'll go on to the next discussion. So sinus tachycardia, accelerated junctional rhythm with AV dissociation. ST elevation with concavity upwards, and the diagnosis was an acute pericarditis with atrioventricular dissociation and accelerated junctional rhythm. So this is the ECG of a 60-year-old male chronic smoker who was admitted with a dyspnea of 1 week duration and had an oxygen saturation of 88%. 88. Now the questions are simple. What are the findings which you see in the ECG? What is the QRS axis of this patient? And what probable diagnosis is causing his dyspnea and desaturation? So friends, I hope you have answered the questions. Again, I will repeat the questions just for clarity. What are the findings in the ECG here? What is the QRS axis in this patient? And what is the probable underlying disease in the patient? I will go on to the answers. Now we'll start off again with the limb leads initially to calculate the QRS axis first. Now here you find that the lead 1 is negative and the lead 3 is positive. So according to the thumb rule, this is a right axis deviation, isn't it? Now if you look at the lead 2 here, lead 2 is biphasic but is more negative than positive. And then you come to lead AVF, this one, right? Here it is more positive and less negative. That's also biphasic. So lead 2 is more negative. Lead 3, AVF is more positive. So the transition should be between 2 and AVF. Now the axis of 2 is 60 and the axis of AVF is 90. So the transition between 60 and 90 will occur at 75 degrees, isn't it? So now what you do? You add 90 to 75. To which side? To the right, because we said he has a right axis deviation, right? So 90 plus 75 will work out to be plus 165 degrees, which is a very significant or extreme right axis deviation, isn't it? The axis is to the right. So that is one thing. Extreme right axis deviation with a QRS axis of plus 165 degrees. Now we will come to the precordial leads. Lead one, V1 shows very tiny S wave. You can't see, it's almost 1 millimeter only, isn't it? Very tiny S wave. Normally you see a deep QS pattern in V1. So the S wave is completely abolished almost, right? Not only that, if you go to V5 and V6, you see very deep S waves. Now, these two findings, and these deep S waves, if you look carefully, it comes to about 10 millimeters in V6. 10 millimeters, I have measured it already. So these two findings, that is the absence of a significant S in V1 and the presence of a deep S in V5, V6, tell you that the patient is having a right ventricular hypertrophy, isn't it? This is a right ventricular hypertrophy. Now I told you that this is a 60-year-old person and has a dyspnea and a lowered oxygen saturation of last 1 week. So this was a patient, and this patient has right ventricular hypertrophy. So all this put together would suggest a chronic obstructive pulmonary disease. Possibly he has an exacerbation in the last 1 week, which has aggravated his dyspnea and caused the desaturation in blood. So friends, I hope that you have been able to answer all this properly. Right axis deviation, RVH and COPD in this patient. So I'm sure today's quiz is over 3 cases only. I'm taking only 3 cases because I can make it more frequent and I'll give you a little more time for evaluation. Now, if you find that the time is not enough for you, you can always pause the ECG and at leisure you can read and try to figure it out yourself. Because I can always explain in the next slide, but that is not important. The important thing is for you to make the diagnosis. For this, 2 things are required. One, you take enough time if you want. And the second thing is you have to go back to your old ECG sessions and revise them regularly, right? So that is important for getting proper interpretation. Now I request you to share this with your friends and colleagues and also subscribe to my channel if you have not already done so. I'll be meeting you again in a couple of days with another new quiz program. Thank you until then.